of the Oncofertility Consortium. And so I'm going to immediately turn the podium over to Rod Mitchell, who comes to us from the UK. You're going first, right, Rod? Okay, Rod Mitchell's coming to us from the UK, and he's going to describe progress that's been going on outside of this meeting in a collaboration that is multinational. And then Ellen Goossens from Belgium will follow, and she'll talk about, all of us have been cryopreserving testicular tissues for patients now for many years, but what are we going to do with those tissues in the future? And so she's going to talk about the readiness of transplant therapies for the clinic, for those patients that have preserved their tissues. So with that, I'll turn the podium over to Rod.
Thank you very much, Kyle, and thanks very much for asking me to come and lead this session. It's an absolute pleasure to be here, but also it's an absolute pleasure to be traveling again for meetings, meeting real human people in real life. And so it's a real pleasure to be able to do this. I'm Rod Mitchell. I'm a pediatric endocrinologist, and I'm also a research group leader. My research group is focused very much on male fertility preservation, hence the reason why I'm doing this today. So I want to kind of introduce you to a consortium that's recently been established, specifically focusing on testicular tissue cryopreservation in young males. So just by way of an introduction, I'm sure all you people in the audience here will be very familiar with this concept, but certainly when it comes to fertility preservation in males, we know that for adult patients who are producing sperm, it's very straightforward and clear that the option for fertility preservation for these individuals is sperm cryopreservation. But for patients who are not yet or not yet able to produce sperm, then the options are more limited and more difficult. And so for these patients, quite often what we're left with is the option of testicular tissue cryopreservation to preserve the somatogonial stem cells within the testis. So that's what this session is really going to focus on. So I'll tell you a bit about the Orchidnet consortium that we've recently established, but what I do want to get across as well, I think is very important, is that the aim of this session is to have discussion, interaction, etc. So as I go through some of the results from this consortium so far, please feel free to come up to the microphone, ask questions as we go, put your hand up, speak out, and there's people on chat online as well who can interact as well. So I'm very happy for this to be relatively informal as we go through. So Orchidnet was set up to primarily enhance collaboration between those who are working on fertility preservation in young males and preserving testicular tissue. The hope was that through this collaboration, we'll be able to combine our clinical data sets. Obviously, each individual center has its own clinical data set, but some of these are relatively limited in terms of numbers. And so trying to put this together is one of the aims of the consortium. We want to be able to share resources, so that's really an important aim of the consortium, to share, again, what are quite often limited resources, and to develop research projects, so to think about the questions that we want to ask and try and answer them in as big and large scale way as we possibly can. And of course, then the ultimate aim of this is really to eventually be able to provide benefit to patients, not just in terms of storing tissue, but in terms of actually being able to restore fertility in patients. So we've set up this consortium with so far 3 main projects that we want to be working on. The first is a survey of provision and practice for fertility preservation, and that's what this discussion is really going to focus on. The second thing we are in the process of developing is a consensus of recommendations for fertility preservation in young males. As many of you may know, there's quite varied practice amongst the different centres that are currently doing this. And so we wanted to try and develop a set of recommendations, not necessarily prescriptive, but at least minimal types of recommendations that we would suggest for those that are trying to offer this as a service. And then the third thing that we have on the list of things that we'd like to achieve is an international patient registry. For anyone who has set up a patient registry, I'm sure you're already aware this is a very challenging thing to do, but I think it's also an important thing to do. We have now much more patients who've had this procedure done, as you'll see in the survey, and so actually knowing what's happening, what we have, and what the outcomes are for these patients, I think is crucial. So this is the Orchidnet survey. This is going to be the main focus of the discussion today. And this is an online survey that went round a number of centres offering testicular tissue cryopreservation. We tried to include as many as we were aware of. We realised that there will be other centres who have not been able to participate in this survey so far. And the survey had 57 items on this, so it was quite a comprehensive survey of current practice. And in terms of the kinds of things we were asking about in the survey, we wanted to know what patients were out there, so the numbers, the criteria for testicular tissue cryopreservation, some of the surgical details for how the biopsies are performed. We then wanted to know about the cryopreservation, the types of protocols that are being used, and the different cryoprotectants and media, etc., that are being used. We wanted to know, importantly, about the clinical assessment of the patients. So what kind of information is being collected on these patients prior to, during, and after testicular biopsy? We wanted to know about the funding and storage. So how are approvals organized? How are local regulations or national regulations implemented? And then finally, we wanted to get a feel for the research activity that's going on and the networks that have been established for testicular tissue cryopreservation. And you can see there on the right-hand side, just an example of the types of questions that are being asked and the layout and the way in which the survey was delivered. It was an online survey, so it was delivered through online surveys. And of course, that makes it slightly easier to put the data together at the end of the survey. So that's really the background, that's the introduction, that's basically what it is that we've been doing over recent months. And what I'm going to do now is go through some of the results. And again, please feel free as we go through them, if you have any questions or comments to make, I'm happy to hear those. So the first part of this survey was to look at the patients themselves and try and get a feel for what we currently are doing across these different centres. And so here you can see a breakdown of the patient numbers. So these are the individual patients who have had testicular tissue cryopreservation since these centres started doing them. And you can see the countries are alphabetical order, so you should be able to find the country whose programme you're involved in. And what you can see, and it was a surprise to me, is that we now have more than 2,000 patients who have had testicular tissue cryopreservation across the centres that we've surveyed. Of course, there will be more centres that we haven't included in this, but that, I think, is actually quite a large number of samples and patients. And it also brings home the fact that we need to be thinking very carefully how we are offering this service and how we're conducting our practice, because we now have quite a large number of samples in the freezer. If we look at the number of patients per year, again, this is an interesting graph to look at. We've split it into the pre-2016. So of course that bar is quite high because that's every year prior to 2016. But if you take 2016 through to 2021, what you will see there is a very clear increase in the number of patients per year that are having this procedure offered. And now we're looking at somewhere in the region of doubling of the number of patients per year over the last 5 years. So this is not something that is going to become less of an issue. It's much more likely to become more of an issue in terms of provision and offering this service to patients. In terms of the age distribution of the patients, we've split them into age categories really based on stage of development. So if you look at the two main age distributions, you can see this is the testicular biopsies that are taken during childhood or an arbitrary early puberty. So this is mainly in children between the ages of 2 and 13. We do have a relatively large number of patients where this is done even in infancy, and then there are some that are in this late puberty category between 14 and 17. So you can see the majority of the children that we're doing this on are in this child and early pubertal phase. In terms of the diagnoses for the patients, we can split them into those who are having testicular tissue cryopreservation for either malignant or non-malignant conditions. And you can see here just over half of the patients are being treated for malignant disease. But we are seeing that the number of patients who are being referred with non-malignant conditions, particularly those that are being offered a bone marrow transplant, is increasing rapidly. If we look at the malignant diagnoses themselves, you can see here that when we break them down into the types of malignancies, general groups of malignancies, then you can see that the majority of these are patients with hematological or non-central nervous system solid tumors, but there are also quite a number of patients there with central nervous system tumors. And then in the other category, it's not quite clear exactly whether these actually really fit into solid tumors when you look at the breakdown of these. So I think to some extent, we can perhaps ignore that other category. So a split there between those three different classifications of malignant disease. Again, an interesting one, I think, certainly from the perspective of discussion. Then when we look at the types of treatments that patients have had prior to their biopsy, you can see that the majority of these patients have had no prior treatment. And of course, this is the optimal situation because we know that we haven't yet caused any damage to the testis by the treatment. Then you can see that there's quite a large cohort of patients who've had low to medium risk gonadotoxic therapy. So again, perhaps some damage to the testis, but not considered to be high-risk treatment. But interestingly, there were a number of patients in this survey who had already had treatment with what's considered to be highly gonadotoxic treatment. And I think that's certainly a point for discussion as to whether those who've had treatment that is expected to be very highly likely to have caused infertility, whether or not those patients should have a testicular biopsy. If we move now to the non-malignant diagnoses, you can see here the breakdown of the non-malignant diseases. And again, for these, the hematological conditions are by far the most common conditions. And the majority of those patients are having a bone marrow transplant as the reason for their testicular tissue biopsy. But we have a few other conditions in the non-malignant diseases. We have metabolic conditions, we have Klinefelter, and then we have other DSDs that are non-Klinefelter conditions, and then also a transgender population who've had testicular biopsy. So I think it's interesting to look at these non-malignant diagnoses in terms of what's currently going on across the different centers. So I'm going to stop with the patients part before we move on to the clinical assessment part, because I'm very keen if anyone has any questions or comments on, particularly on those first few groups and results. If anyone has any, then we'll have those before we move on. Yeah. So I'll repeat the question. So Ellen's asking whether or not the transgender patients, about the use of the tissue from transgender patients, And I can't answer the question from the survey because the survey didn't actually discuss the future use of the tissue, and specifically didn't ask that for specific groups either. So it's difficult to know exactly how it's planned to use those tissues, or in fact for those transgender patients exactly what the clinical scenarios were, etc. as well. Yeah.
What was this? Do you know anything about the situation for those patients?
So from the survey, we don't know what the clinical condition was of the patients that were in the 14 to 17-year-old age group. The other thing that is, I guess, interesting to think about is for those patients, how many of them were actually pubertal? How many of them were late pubertal? How many of them were already producing sperm, maybe had adult testicular volumes? And then we get into the question of, for those patients, would it have been possible to obtain sperm rather than a testicular tissue biopsy? The survey was designed to ask whether the testicular tissue biopsy, it's testicular tissue biopsy for obtaining somatogonial stem cells, not sperm. But we don't know for those individuals whether they were also had attempts to obtain sperm.
So Rod, I think is universally true that there are many patients who have had a previous exposure to a gonadotoxic treatment. Did you have any centers in the survey that would not freeze under those conditions, or are all centers doing that?
Sorry, just repeat the last part, I didn't hear that.
In the survey, were there any centers who would exclude a patient with a previous gonadotoxic therapy, or do all enroll patients that have had a previous therapy?
Yeah, so I think that wasn't asked in the survey. We're obviously discovering lots of questions and things that weren't asked in the survey. That's always what happens. But there are certainly centres who will not take a testicular biopsy from somebody who's had any previous treatment. There are some centres who will only take testicular tissue biopsy from someone who's had low to medium but not high risk treatment. But then obviously, as we've seen there are some centres that have taken from patients who've had high risk treatment. I think that's definitely an interesting question from my perspective. From Edinburgh, we originally, when we set up our study, we set it up so that we only had patients who'd had no gonadotoxic treatment whatsoever, including low risk treatment. Very cautious how we set it up to start with. We have now relaxed that slightly to allow some of the low to medium risk treatments, but we wouldn't take testicular tissue from someone who'd had high gonadotoxic risk treatment already.
So that actually raises another interesting question, which is, what's your cutoff where you define high and where you define medium to low?
Yeah, brilliant question, Kyle. So everyone who's read the papers has probably seen the arbitrary cutoffs of percentage risk of infertility, and for that often there is either a regimen or a particular drug or dose of drug that will sort of determine which category they're in. There's also the cyclophosphamide equivalent dose as well, which you can use, and you can have a cutoff there for that. But we have to remember that this is arbitrary to some degree. So although we talk about high risk, medium risk, low risk, we can't be absolutely sure for the regimen. And also, every individual might be slightly different. So it is, there is some kind of, there's certainly some debate about that. But if you have a patient who's maybe had, a bone marrow transplant with very high dose alkylating agents or something like that, then, I think in those kind of situations, you say, well, I'm not sure what the justification for that is. But I'm saying that I'm happy to hear other thoughts and comments and the like.
I think I'm pretty loud, but I think that's the question, and trying to get Because when you look at the literature, right, if everyone's using a different cut point and you're looking at outcomes eventually, it becomes challenging to be able to compare across studies.
Yeah, absolutely. So I think that's one of the reasons why, again, we wanted to set up this consortium, because it would be nice to be able to have some kind of standardized guidance or recommendations that would then allow us to put our data together and actually combine it in such a way that we can compare across centers, across studies. It's a big ask, but I think it could be. On the subject of gonadotoxicity, is anyone who has a program or is involved in a program, do you have cutoffs in terms of gonadotoxicity, in terms of your cyclophosphamide equivalent dose, and what do you all use? How does everyone's differ?
I think you're right. It's very controversial, but actually the Pediatric Initiative Network of the Oncofertility Consortium pulled together 26 clinicians and researchers, and we went round and round and round and round about cut points. And the CED that we were settled on, somewhat grounded in literature, but grounded a lot in expert opinion, was 4 grams per meter squared. And that was based on Kyle's protocol and published.
2021 or 2020?
I do know about it, but I'm keen to.
Do you want me to keep it? Okay.
Yeah.
Thank you, Veronica. But so we did publish for males and females risk stratification, and again, it's not perfect, but it was a starting point to have similar cut points and definitions, and it's in JYAO in 2020.
Brilliant. Okay.
Yeah. Okay. So the question is do we have sufficient evidence to suggest that high-risk chemo exposure is sufficient to ablate spermatogonial stem cells in prepubertal individuals at the time of biopsy?
Yep. So it's a good question. Do we have the evidence from the high-risk treatment will ablate the spermatogonial stem cells? I don't think we have definitive evidence of that. And then it becomes a question of risk-benefit in terms of, is it worth the risk of doing the biopsy in the patient for what potentially might be a significant, if not complete, reduction in spermatogonial stem cells. So I don't think we have definitive evidence on that. Does anyone else feel that they know of definitive evidence that would do that, Ellen?
Well, it's not big evidence, but in our center we have some tissue banked from patients who had already undergone high-risk treatment because they really wanted to have something stored. And indeed, we did find spermatogonial stem cells in these samples. And I will present next Wednesday in my talk also data about sperm recovery in these patients once they become adults. So I think there is a possibility that spermatogonial stem cells really survive these high-risk treatments and that they are able to function well.
Yeah, no, that's good, Ellen. The other thing that there is out there is certainly plenty of evidence that the sort of exposure to relatively high doses of alkylating agents will drastically reduce the number of spermatogonia. But I guess the question then also becomes, even if you've wiped out the majority of your spermatogonia, are there still some surviving spermatogonial stem cells which are capable of repopulating? So you might lose 90% of your spermatogonia, but it might not mean that you're not going to get some regeneration. So again, I think that's, I guess from a research point of view, that's another major thing that we need to be understanding.
So
Can I?
is that, I mean, maybe you'll get to this, but is that the hope with the registry, is to capture that?
So I think
data?
there's two parts to the idea for the registry. The first is to have a clinical patient registry, which will have the number of patients, it will have the diagnoses, it will have some clinical information about them, etc. So that's sort of one hope of the registry. But the other hope of the registry is to be able to have either within that or sitting alongside it research data. So data from histology, from immunohistochemistry, et cetera, to be able to then look at pick out patients, they've had this treatment, here's their tissue, this is their histology, this is their immunohistochemistry, et cetera, et cetera.
Yeah, that would be very powerful.
It would be very powerful. As I said already, it's a big challenge to organize, but I think that's why we need to get together as a large consortium to actually make this work.
Rod, can I ask the question, sort of flipping the comments before about chemotherapy to the leukemia patients, where it may be beneficial for us to take it after they've had chemotherapy to reduce the risk of circulating leukemia cells?
Yeah, that's a good question. That's Deborah, isn't it?
Yep.
Yeah, that's a good question. I think there is possibly some justification for that, although I suppose then you're in a situation where if it's initial standard treatment for leukemia, which would not be considered high-risk treatment, then your initial round of treatment followed by a biopsy prior to any further treatment perhaps might be an option. Does that answer the question, Deborah? Does anyone have any other thoughts about that? We wouldn't offer testicular tissue cryopreservation to a patient prior to standard ALL treatment because we don't consider it high enough risk to justify a biopsy, but others may feel differently.
Yeah, so I guess the question then goes on as to what sort of time, washout time, would we need after even the mild level of chemotherapy before we took the testicular biopsy?
Yeah, so I would be keen to hear other people's thoughts on this. For a patient who had leukemia, they would get their initial treatment. They would then not have a biopsy after treatment, but if they were to relapse and then require further treatment, we would do it at that stage. So we don't really need to worry usually about the time period between those two. But I guess if you were thinking about doing it soon after the initial treatment, then you might have to think about that. Has anyone in that situation where they're looking at taking tissue from leukemia patients soon after treatment? So again, if anyone has any comments on that, we would have, as I was saying, for our patients, they would get their standard treatment without biopsy. They would then only get a biopsy if they relapsed, and they would get it prior to their bone marrow transplant or whatever subsequent treatment. So they would have active disease at that stage. And from our perspective, the way we run our services, we have testicular tissue cryopreservation and future use of tissue separated completely. So they can have their tissue stored, but then what happens to their tissue later on will be subject to further discussion and further approval to use that tissue. But for those who have storage and use together in their whole protocol, perhaps they may have to describe what they would do in the situation of a patient who's got leukemia and potentially active disease, in terms of would you actually do a transplant in that situation or not. I'm sure there are probably some thoughts on that.
Just following up on that. So we would, if they relapsed, would treat them till they were in remission and then take it. So they would have had recent chemo, but then we know that we feel good about the tissue being disease-free. I don't know if anybody else does.
So I think it's a really interesting thought, isn't it? Because you're kind of then, it's almost like a balance then between getting the tissue in the best possible condition to be able to preserve their fertility in the future, versus reducing the chances that there are malignant cells in that tissue. And I guess you could argue that in two ways, couldn't you, in terms of which is the right way to go. But it's interesting that that's the approach.
So I'll just add that that's also usually the scenario in which we see leukemia patients, where they're basically put into remission, but are going to have to come back for a bone marrow transplant. Although I wouldn't counsel the patient that the tissues are disease-free. I don't think we know that, and I think we do a lot of counseling about whether or not it would be safe to transplant those tissues back into the patient body. I also wanted to add a little bit of flavor to Lillian's discussion about qualifying and just share our center's experience and also some data about patients who've had previous exposure. So we have an inclusion criteria where if a patient is going to receive a dose of 4 grams per meter squared cyclophosphamide, then they would qualify for the trial because we consider that they're at significant risk. We actually don't have an upper end cutoff, but we understand, of course, that the higher dose of treatment that a patient gets, the more likely it is that their stem cells have been depleted. And so we won't disqualify a patient, but the rigor with which we counsel about the potential use of the patient increases with the increasing dose. And related to evidence, and part of how our protocol has evolved over time with experiences, but I'll just tell you a story about it gets to exactly the point that you said. Every patient's different. So we used to have an upper end cutoff. If a patient had 7.5 grams per meter squared, then simply they disqualified. Until we had 2 patients qualified on a protocol who were just under 7.5, let's say 7.3 and 7.2. One patient completely depleted of spermatogonia. Other patient, you couldn't distinguish it from somebody who had no treatment. And so that makes a cutoff kind of arbitrary. So rather than establishing a protocol cutoff, we just counsel very strongly about the potential use of the tissue in the future, that every patient is different, but we wouldn't exclude them from the protocol.
Yeah, that's interesting. I think the individual variation is definitely an issue. Any other thoughts, comments?
Was based on hematologic toxicity, actually. So I always wonder, are these really true numbers? I mean, are they really equivalent in terms of gonatotoxicity?
Yeah, and I guess the other thing to add is that the CED is based on alkylating agents primarily. And of course, there are other agents that are used, which, although they may not be highly gonatotoxic, will contribute to the gonatotoxicity. And so again, even when you use CED, there may be other things on top of that, obviously radiation and other chemotherapy agents that may be contributing. Mitch, yeah.
Yeah, we have another question from the chat online. And the question is, with regard to leukemia, can we look at biopsies from pubertal patients to see at which point after chemo the spermatogonial stem cells start dividing again? This may at least give some information as to how soon after chemo to consider biopsy.
Yeah, I think that's a good point. I guess we don't know, we certainly don't know for sure exactly what the somatogonial loss and somatogonial stem cell loss is with chemotherapy, but we definitely don't know what the recovery is like post-treatment, or we don't know for sure what that recovery is like. I don't know if some of the monkey data gives an idea of time to recovery. I'm looking at Kyle, but
really the monkey data, it's hard to tell because you can't assay a single test as at 2 different time points. So all I can tell you is that there are plenty of times where spermatogenesis will disappear for a while and eventually come back, and sometimes fairly rapidly. That means within 6 months or so. Temporary infertility after a treatment obviously doesn't mean permanent infertility. And of course, the more stem cells that are left, the more quickly you'll begin to see sperm in the ejaculate.
Yeah. So I think we'll maybe move on to the next section, but I'm sure if there are other questions about that particular thing, we can kind of pick them up later on. So the second part of the survey was to look at clinical assessment of patients. And the slide mover has died. There we go. So the first question was, what kind of clinical assessment is taken pre-biopsy? And for this, we asked about whether patients underwent Tanner staging and whether testicular volumes were measured. And you can see here the answers to these questions. I think it's interesting that there are quite a number of no's in both the Tanner staging and the testicular volume part. And the reason I think that's surprising to some extent is that presumably somebody has looked at the testicles of the patient prior to the biopsy, and therefore if they've been looked at, obtaining a testicular volume should be fairly straightforward. If they haven't been looked at, then of course you don't know for sure that this patient doesn't have cryptorchidism or another testicular disorder which may impact your decision on whether you take the testicular biopsy or not. So I'm going to put out my opinion here, and I'm keen to hear what other people think. I think all patients who are having a testicular biopsy should have their testicles looked at and a testicular volume taken. And of course, the other thing is that if they have 12, 13, 15, 20 mil testes in a sort of 14, 15, 16-year-old, that's again going to change your decision in terms of what you're going to offer them. So any counter thoughts to that, or just interested that that's not the case necessarily everywhere? Oh. No.
I think that there's a lot of times that we're having discussions about what fertility preservation option you're going to offer someone, and there's no standard staging anywhere in the chart. So
Yeah, so
yeah,
Totally feel that's true, right?
like it just says like testing like normal, right? So
normal, yes, yes. Yeah, so I'll just share one incident that we had, and I'm sure similar things have perhaps happened elsewhere. We had a patient that was to get a testicular biopsy. They were examined by a member of staff, let's just say, and their testicular volumes were recorded. The patient went up for their testicular biopsy, was on the table, and it was discovered that patient had cryptorchidism on the table. So, and that's even with somebody apparently checking the testes. So it's, you know, I think it's really important thing to be trying to ensure that it's done for patients prior to their biopsy. Question?
So yeah, I have another question. I should say all these questions have come from Scott Gabrielson through the chat.
Okay.
But his last question is what was the overlap of patients that had neither Tanner staging or testicular volumes? And then the second one is also is in an issue of who is doing the counseling versus who is doing the biopsy.
Yes, that's a good question. I would need to look back at the data to see how many didn't. There were certainly some that didn't have Tanner staging or testicular volumes. I can't remember how many there were. What was the second part? Sorry.
Right. And like, is this an issue of who's doing the counseling versus who is doing the biopsy?
Yeah, I think so. I think sometimes there's several people involved in the whole process, and actually it's not always clear whose job it is to do whichever bit. And certainly the person who's counseling is not always the person who's examining the patient. The person who's consenting isn't necessarily the person who's done the counseling, and so on and so on. So it becomes difficult, but I think that's where perhaps a protocol with a pro forma where everything has to be ticked before patients signed off to be able to have their biopsy is something that you can consider to make sure it's been done. But even when it's been done, as I said, you sometimes get a surprise. So my slide mover is not working very well. So Mitch, can you move that on?
Yeah, we also have another question. Where there no in some of the under 2-year-olds, less than 2-year-olds?
Sorry, what?
Were there any like no Tanner staging or no testicular volumes, I think is what they mean, under 2-year-olds for this?
Yeah, so some of them were the younger patients, and perhaps the assumption there is, well, this patient's not pubertal, so therefore we'll just do a biopsy. But again, you don't know what you're going to find when you get them on the table if you haven't looked and recorded what's there.
So I'll say that our center is one of the ones that doesn't do either one of those things. And of course, the Tanner staging, for obvious reasons in some cases, we do ask those kinds of questions if patients are peripubertal, because then we want to think about whether there could potentially be sperm in the testis. But the question I have, so it seems clear to me from your comments that you do an assessment before surgery. So does that require an extra visit, sort of a pre-surgery visit to do those assessments before a patient shows up in the OR for biopsy?
No, not really, because there's a few things that always need to happen. The first is the patient needs to be counseled. So that's normally a separate if you like, visit or at least assessment. The person who does the counselling quite often is someone who can measure the testicular volume, so they'll quite often do it when they're doing the counselling at that stage. Then the patients will need to be consented, and the consented is done separately to the counselling. So that's a second opportunity to check the testicular volumes. And again, the person who's doing the consenting often is someone who can measure the testicular volumes. And then the third option, which has occasionally happened, is if the patient lives a long way away and isn't actually coming in, etc., but it's coming in on the day, sometimes then we'll actually do the examination on the day of surgery, on the understanding from the family that if we suddenly find something we weren't expecting, we might have to cancel it. But so we have enough opportunities to do it as part of the process without an individual visit for that. But again, every centre probably will have a different way of being able to do it. Okay, so we'll move on. There we go. Okay. So the next thing in the clinic assessment is blood tests. So do patients have blood tests taken pre-biopsy? And you can see here for the graphs, I've put 13 is the axis there for all of these graphs. That's 13 centres. So you can see the number out of the total number of centres on each graph. Here you can see the types of blood tests that are done for patients. So gonadotrophins, testosterone are by far the most common, as you might expect. A number of centres are doing inhibin B and AMH. And then there are some centres who, again, are not doing blood tests prior to biopsy. Again, I think what is useful from this kind of information is that you can then look at your results prior to biopsy. You can follow the patients up, monitor their biochemistry and see what's happening and match that obviously with their pubertal development as they go. So those are blood tests that are performed prior to biopsy. Any questions about clinical assessment of patients prior to biopsy? Any thoughts, comments?
I guess I was just curious. You were saying to get a baseline and a follow. When I initially saw that, I was wondering if we're getting that in lieu of actually.
Yeah, so I think some centres do bloods and rely on the bloods as an indicator of puberty. I'm not sure. I think that will be helpful in some situations, but I'm not sure just simply getting a testosterone will give you the answer that you need, or gonadotrophins will necessarily give you the answer that you need. Again, I think testicular volume is a better measure. Yeah, but that's true. I think there are definitely centres where they're doing the blood tests for that reason. Okay, so in terms of the biopsy itself, what are people doing in terms of actual practice? So we asked about whether patients are having unilateral or bilateral biopsies. And what you can see here is that we have orchiectomy. Here is those centres who are only doing a total unilateral orchiectomy, so removing the whole testis. So there are a number of centres that are doing that in all patients. Then we have a group of patients who are only having bilateral biopsies, so they're having biopsies taken from both testes. We have some centres who are either doing unilateral or bilateral, so they will decide for each individual patient. It's not clear how they decide which ones get unilateral and which ones get bilateral, but there are those. But most of the patients are having a unilateral biopsy for storage. And certainly in our centre and in the rest of the UK centres, then unilateral biopsy is what we would perform. And the reason we do that is we want to leave a whole normal testis untouched, just in case that patient is going to recover their fertility, and then we haven't done anything at all to damage that second testis. But again, there's quite a bit of variation in terms of the types of biopsies that are taken. How much of the testis is biopsied? So we gave a number of different options for the proportion of the testis that's biopsied, but in fact, all of the answers were in the range of between 10 and 30%, and you can see it split about 50-50 between 10-20 and 21-30. So that was fairly consistent across all of the centres in terms of how much is taken to then leave sufficient testicular tissue for the patient should they recover their fertility. So the next question, oh, sorry, Ellen, you've got a question?
Is this the percentage of one testicle or the percentage of both testicles? So
this is the percentage of one testicle, if I remember rightly, based on those that have had unilateral biopsies. I think in the ones that had bilateral, if I remember, the proportion of each testis was smaller, giving a larger total proportion, if that makes sense. Maybe not entirely clear. So the next question is, for patients who are pubertal, do they get offered either TZ, so testicular sperm extraction, so an opportunity to try and take sperm from the testis during the surgery, and you can see here that the majority of centres said yes, that they do this, and for those that did do a TZ procedure, they would try and then obtain the sperm from that sample either in theatre or more often during the processing of the tissue further on. So this is interesting to see because certainly in practice it's quite challenging to be able to do TZ at the same time as doing a biopsy for somatogonial stem cells, to have the logistics, the people, the facilities, etc., to be able to do that. So it was quite, in some ways, it was quite reassuring to see how many centres are actually able to do this. I don't know if anyone has any thoughts about TZ and trying to do TZ at the same time as storing tissue for somatogonial stem cells. Mitch?
Yes, we have a question again from Scott Gabrielson. Did you look at whether electroejaculation was offered to pubertal patients prior to TC?
So we didn't ask about electroejaculation or penile vibratory stimulation or any of those other types of options. That's actually maybe something we could ask about, whether centres offer that or not.
can I comment on that?
Yeah.
We excluded pubertal patients in this survey if they were able to give sperm, was it by masturbation or through electroejaculation. These patients were not part of this survey.
Thanks for the reminder, Ellen. That's right, we did. Okay. Can we move it on again, Mitch? Okay, so the next thing we asked about was obviously a really important consideration, which is post-operative complications, post-biopsy. So we asked whether or not centres had a specific protocol for monitoring for post-op complications, and you can see that just over half of the centres did. I guess for those that don't have a protocol for monitoring, the question really becomes, how are we ensuring that there aren't any post-operative complications from these patients? How are we recording it? And are we actually picking up and capturing all the patients who've had any potential complications? The frequency of the complications you can see here. In the majority of cases, it was either no complications or up to 10% of patients would have some form of complication. But again, it increases to a group there that are reporting 11 to 20%, and then one section there that's 21 to 30%. So there are some centres reporting a relatively high rate of complications. But by far the most common complication, and perhaps this is why the rate that's being reported is relatively high, is that post-operative pain was one of the complications that we asked about. And we asked on the basis of moderate to severe pain, accepting that mild pain is probably something that is very difficult not to have with a testicular biopsy. And so this is the reported complication of post-operative pain. Up to 25%, so 0 to 25% was by far the majority, but then there were some that were reporting much higher rates of post-operative pain. And I guess the eagle-eyed amongst you will have spotted that the rate of complication here is much higher than the overall rate of complication reported in the previous slide. So I think that's perhaps an issue with the survey and how it was conducted. But I would take from this that actually the potential for pain is really quite high in these patients, and it's something we have to be really, really wary of. And certainly I would say for our patients, pain has definitely been an issue after treatment, and it's probably under-recognized and underreported. And if you're not actually actively collecting that information, you will, I suspect that you will actually miss patients with significant pain. So we also asked about what kind of analgesia these patients got. So you can see that some of these centres were providing local anaesthetic in theatre prior to patients coming back. The majority were paracetamol or non-steroidal anti-inflammatories, and then a few centres were using opiates, and some had others in their group. We almost always use opiates in our post-operative pain because that's about the only way we've really been able to get on top of pain for the majority of these patients. So I think that's something just to really bear in mind for those that are doing this, is to think very carefully about pain and analgesia. I don't know if anyone has any experience or thoughts on either those complications or pain. Is it something that people have seen a lot of in patients, or?
Yes, hello. My name is Aisha Siebert. I'm a urology resident at Northwestern, so we routinely operate on testis. Typically for pediatric patients, they'll have a sacral nerve block before the procedure, and that gets them through the initial phase when they are most likely to experience pain. I will say that when we open the testicle, we typically avoid NSAIDs because of the risk of intertesticular hematoma that could cause further functional impairment. But patients will often go with a small dose of opioids, oral opioids, that help control the pain in that initial phase.
Yeah, that's interesting. I think the non-steroidals is also an issue with certainly with the cancer patients, depending on their diagnosis and whether or not they should be getting non-steroidals. Yeah.
I was also wondering if in your data you were able to stratify who was doing the actual biopsy, because sometimes it'll be the general surgeon versus the urology team. So I wonder if there's a correlation between outcomes if it's dependent on who's doing the biopsy.
Yeah, that's a really good point, actually. We didn't ask that in the survey, but it's probably something that we could include in future surveys, because there is variation on who actually does it. And in some centres, there's a designated pediatric surgeon or urologist who is designated to do this particular procedure for these patients. In other centres, it's whichever general surgeon or is involved, so it does vary. So that's post-operative pain. The other complications that can come along with testicular biopsy are infection and bleeding, and the overall rate reported from the different centres was obviously very low. for both infection and bleeding, so somewhere in the region of 1% for bleeding and up to 5% for infection. So, and that would fit with certainly the literature so far, looking at these particular complications, that it's somewhere in the region of up to 5%. So that's the biopsy information, protocols, etc. Anything else that anyone wants to add about the biopsy before we move on to tissue transport and media? Okay, so this is now getting a little bit more technical in terms of some of the specific science behind the biopsies, etc., and how we do our cryopreservation. So the first thing that we asked about was the tissue transport media. So how is the tissue transported and in what media? And you can see here the different media that are used. There's quite a variation in what people will transport their tissues in. And probably most importantly, what's written at the bottom of this slide is that all the centres have the intention of transporting their tissue to arrive for processing within 24 hours, which is obviously important to think about in terms of the length of transport. Some of the centres will obviously have occasions where the transport takes longer than 24 hours, and in that case the tissue will still be stored, but it will be recognised that that took longer than was actually expected. So the tissue needs to be ideally transported as soon as possible. What's the impact of the transport time on the tissue? Well, we still don't know for sure. There are some studies out there that suggest that perhaps the tissue could be maintained in a viable position for longer than 24 hours, but for practical purposes, most of the centres are currently aiming to get it processed within 24 hours. In terms of the temperature that's transported on, the vast majority will transfer tissue between 0 and 8 degrees, so in cool boxes, ice packs, etc. There are some centres that will transport it uncooled at just ambient temperature. And then for those that are transporting between 0 and 8 degrees, about half of them will have some kind of temperature control system within their transport, whereas the rest don't have a controlled option for transport. Yep.
So I should know the answer to this question, but what does controlled mean? Does it mean you're monitoring, or does it mean you're actually controlling the temperature?
Yeah, I should have clarified that. So a temperature logger, something to ensure that the temperature was maintained at the temperature it was supposed to be at. So if you transport it with a cool pack or whatever, but you're not logging it, then that would be considered uncontrolled. I should say as well, for that, it may be that some people who've answered that survey have not answered it in that way. So for all of the questions that we've asked and the answers that we've got and things, we will need to just go through all of that and just make sure that we haven't had situations where the question has been misinterpreted in some way. In terms of the cryoprotectants that are used, we asked firstly whether all the constituents are CE marked, so all of the constituents are considered clinical grade. And most of the centres were able to say that the cryoprotectants used were clinical grade. There are a number of centres who are using some constituents of the cryoprotectant which are not clinical grade. We're included in that. We're not able to source one of the constituents as clinical grade. That's important to bear that in mind. In terms of the cryoprotectants itself, you can see here almost all centres use DMSO as their cryoprotectant. A couple of different concentrations are commonly used. And then there is some centres that are using ethylene glycol as their cryoprotectant. There are a number of additional constituents to the cryopreservation medium. You can see them there on the graph. These are the types of things that are routinely added to the cryoprotectant media. HSA is human serum albumin, which most centres use, and again, sucrose. Most centres put sucrose in their cryoprotectant. So any questions on cryoprotectants or cryopreservation process? Okay. Clinical assessment of patients post biopsy. So, clinical assessment of tissues post biopsy. So we asked whether or not the tissues that are stored are routinely assessed for presence of germ cells and for malignancy, either using histology or immunohistochemistry. And you can see here that the majority of centres will do some form of assessment on the fresh tissue that they receive from the patient. So this will often be at least a pathological assessment by the pathology department. Sometimes it's more detailed assessment of the tissues. When the patients do have their tissue assessed, then we asked whether or not the results of that that assessment is discussed with the family. And you can see here there's quite a split in what is current practice. So almost half will always discuss the results of the pathology with the families. And then the rest are split between those that will sometimes discuss the results and those that don't discuss the results. So I don't know if people have thoughts about discussing the results of the pathology with the families. We tend not to discuss the results with the families in terms of germ cell numbers and overall histology, etc., because the majority of these tissues have apparently normal pathology, and we don't know for sure really what that means in terms of when we use the tissue in the future, whether it's going to be good, bad, or not. So we feel that we are perhaps raising hopes or reducing hopes on the basis of something that's not really a very clear science. So we don't do that. The only situation where we might discuss with the family is if we identified malignancy within the testicular tissue, which obviously is of clinical relevance, we would discuss that. But I don't know if anyone has comments on whether or not they discuss the results of the pathology with the families, and in fact what they tell them in terms of what it means for their future fertility. Does people in the audience discuss the results of the histology or? Yes, Ellen's nodding. So Ellen does, Kyle does, yeah. So in that situation, if you had a testicular tissue that had seminiferous tubules and some germ cells, how do you equate that? Do you just give a very general, there are germ cells present, so hopefully it should be okay, or do you give them numbers, or how much detail do you go into with that?
So for us, it's just germ cells present, yes or no, because of course, if there are no germ cells there, a family may not want to continue storing their tissue. Of course, they get charged every year for tissue storage. We don't quantify because, in my opinion, the numbers are meaningless. You know, every patient is different in terms of the number of germ cells in their testes.
Yeah, similar for you, Ellen, as well. Yeah. Okay. Question, yeah.
Yeah, again from Scott Gabrielson. So testicular biopsies are known to not necessarily represent the entire testes. For prior chemo, do we see pockets of spermatogenesis, in which case a biopsy may show germ cells, whereas the bank sample may not, and vice versa?
Yeah, I think that's a good question. I think it's a really difficult one to work out how you approach that, because you're right. You may take a biopsy, there may be not very much in there, and that doesn't necessarily represent what's going on in the rest of the testis, or vice versa. So I think you can only go on what you can see in the biopsy, and you can only make some kind of judgment as to what that might mean for the rest of the testis, but knowing that it's not necessarily representative of the rest of the testis. So again, coming back to what Kyle and Ellen are saying, again, that means that trying to give some kind of number of germ cells in that bit of tissue is not necessarily going to tell you what the outcome is going to be for that patient. Okay, so we'll move on. So the next question was, not only do you look at the pathology and the histology of the fresh tissue when you receive it, do you actually do some kind of assessment of the tissue post-freezing? So are you doing some quality control that your freezing process is still able to preserve the tissue? And so most of the centers are not doing this. So they're freezing the tissue, leaving it in the freezer, but not being sure exactly what that frozen tissue is like and what the impact of the freezing procedure has been on that tissue. You can see here what the individual centers that do this are doing. So mostly doing histology to look for germ cells, or immunohistochemistry to look for germ cells, and occasionally doing histology for looking for malignancy. But this is not something that's routinely practiced. So knowing that the frozen tissue is in as good a state as the tissue prior to freezing, and how good it's going to be when you come to thaw it and use it is not so well known across the different centers.
We do have another comment real quick, but they were just, Scott was saying that it just worries about using a small part of the biopsy to determine whether to discard a sample, or discard a sample, maybe discard samples that still have cells in them. So I don't know if you have a comment to that.
Sorry, Mitch.
I'll say it again. So
yeah, sorry.
They worry about using a small part of the biopsy to determine whether to discard a sample that that may still have some cells in them.
So that's a good question. Because we don't do that, we will just continue to store the tissue for the patients, and we also don't have the funding issue that perhaps other centers have in terms of discarding them. So I guess that's to Kyle then. If you have a situation where you don't see any germ cells in the bit that you look at, and then you're discussing discard, what about the possibility that there are some germ cells in the rest of that biopsy, I guess?
Yeah, so we just provide information, and the information would include that this is a piece of a sample. It may not represent the rest of the sample, but I think it's fair for the family to understand that, at least in the piece that we looked at, that there were no germ cells there. This is not prescriptive. It's always up to the family to decide whether they want to continue storing their tissue.
Yeah. Ellen?
What we do is, if we don't find germ cells in the biopsy, we thaw a second one, just to be sure. Well, we can never be sure, of course, but just to have a confirmation. Sometimes we do find germ cells in the second part. Sometimes we don't. But we always discuss this, of course, with the patients and their parents. And I don't think we have ever discarded tissue. We always keep it. Just to be here, just in case.
Yeah, we would be the same. We would just keep the tissue on the basis that we don't know yet what the future will hold for these patients. Okay, we'll move on, Mitch. So in the UK, storage is covered by, the best way to put it is it's covered by NHS funding, so National Health Service funding. So it's not, patients don't have to pay for their storage. I don't know if it's the same in Belgium. So again, it's not as big an issue in terms of discarding samples and patients having to make the decision based on whether they want to or can afford to continue to store it. Okay, so patient follow-up. You'll be pleased to know that we're nearly done with the pie charts. You're probably sick and tired of all these pie charts. We're getting to the end, and Ellen, there will be time for you at the end. So post-biopsy follow-up, do you do follow-up on your patients after biopsy? So roughly 50-50 will follow up their patients beyond the biopsy. And in terms of the frequency of the follow-up, it varies, but most of them are 12 months plus for frequency of follow-up. There are some patients who are seen much more frequently than that post-biopsy, either 3 to 6 or 6 to 12 months, but most are relatively infrequent follow-up. And certainly in our centre, and I presume in other centres as well, this is usually coordinated with a planned follow-up for their oncology diagnosis, etc. So the late effects clinic or something. So they're not ending up getting additional follow-up type appointments. In terms of what's done for patients post-biopsy, then 50% of the patients or 50% of the centres or thereabouts will do blood tests post-biopsy. And again, the same types of blood tests that we looked at in the pre-biopsy type situation. But of course, in post-biopsy and subsequent follow-up, these are obviously very useful in determining whether or not patients have are going through or have gone through puberty, but also whether they are starting to develop primary testicular failure, either as a result of their treatment or as a result of their biopsy potentially. In terms of other types of clinical follow-up or clinical analysis, then we asked about semen analysis. So round about 3/4 of the centres were routinely performing semen analysis on patients prior to their treatment, prior to their biopsy, after their treatment or after their biopsy. And the age at which they had the semen analysis performed was 1/3 of the patients were done at 16, 1/3 at 18, and then the rest were other. And in the other category, that was really often basically variable, dependent on a variety of things, such as the clinical situation, the need or desire of the patient, etc., as to when they wanted that. But semen analysis is relatively frequently performed in these patients who have biopsies. So the last couple of slides are really now looking at funding and research. So Kyle's already mentioned or asked about funding as how this is done across the various centres. So you can see here about 50% of centres are funded by a health service section there that are funded privately. Some of the programs are funded by charitable donations, and then there's a class for other, which actually largely are in some way, shape or form charity or philanthropy as well in terms of the funding source. So this is how the different centres are funding their programs. And for how long testicular tissues are stored for and what happens to the tissues, you can see here that the storage time for 50% of the centres, or just above 50%, can store for more than 50 years. And then you can see the rest of them in terms of the length of storage. The thing to point out perhaps is that where it says, for example, 10 years storage, of course, for a 2-year-old or a 4-year-old, that's not going to be really terribly helpful. So where you see 10 years and perhaps 20 years, in those situations, it's likely that these centres are able to apply for it to be extended, but they can only apply for 10 years at a time, if that makes sense. In the UK, we can store tissues for up to 55 years, so as long as those patients should hopefully ever need them. What happens to the tissue at the other end? So if the patient is no longer able to use the tissue, if the patient dies or no longer wishes to keep the tissue, then what options are given for the tissue? So you can see there's a proportion where the tissue is just simply discarded. The majority of situations allow for the tissue to then be used in research, but prior consent needs to be given for that. There are a small group there where research can be conducted on the tissue without consent of the family or the patients, and then again another category for that. So you can see in the majority of these situations, tissues can be used for research with prior consent of the patients, if the patient no longer requires it for whatever reason. And then in terms of the types of research activity that is undertaken, the vast majority of centres are able to obtain some tissue for research as part of their testicular tissue cryopreservation programme. The amount that they can take for research, and this is the proportion of the biopsy, not of the testis, is up to, in some cases, up to 50% of the biopsy, But most situations, it's only a very small portion of the tissue that can be used for research, somewhere up to 10% in most cases. And in terms of what types of research activity are being undertaken, you can see here that all of the centres that were taking tissue for research are working on some form of in vitro somatogenesis, and the majority of centres are working on techniques that involve tissue transplantation, which is what Ellen's going to talk about shortly. So you can see that those two activities are being widely practiced. And I guess what we should also think about is not only should we be thinking about how we can coordinate and collaborate on the clinical activity that we do, but also, given that there's such consistency of the types of approaches that we're using, can we actually combine some of our research questions and research activity to maximize the use of these tissues? So I'll stop now. That was quite a large number of charts and graphs. I'm sorry if your eyes are completely done by having watched those, but I would like to acknowledge all the people who are involved in the survey, members of the Orchidnet Consortium, who you can see here. And just to say as well that for those of you who are involved in testicular tissue cryopreservation programs who haven't been involved in the Orchidnet Consortium or the survey, etc., who want to find out more and perhaps become involved, then we'd be delighted to have you join us with this. And I think with that, I will stop. But any final questions on the data that I've shown, or thoughts, comments, very much appreciated.
Well, thank you, Rod, for leading a great discussion. Obviously, there's a lot of involvement and a lot of curiosity about what we're all doing. Our next speaker is Ellen Goossens. She's from Belgium, and as Rod said, she's going to tell us about what do we do next now that we've frozen the tissue and what's the potential for taking transplant technologies to the clinic.
Thank you, Kyle. I will give a very short talk today because on Wednesday I also will give a talk about fertility restoration in males. The idea of today is just to give a short overview of what has been done preclinically and then have a discussion about what would be the next steps. It doesn't work. You can go to the next slide. So as you all may know, there are two ways of transplanting spermatogonial stem cells back into the patient, or you perform testicular tissue grafting. Here you transplant the tissue piece as a whole, or you can digest the testicular tissue and transplant spermatogonial stem cells as a suspension. The very first studies have been performed in mice. And in the first studies, the testicular tissue was transplanted under the back skin of mice. This worked very well if you transplant mouse tissue to the back skin of the mouse, with the sperm cells being produced after a while. If you transplant human or primate tissue to the back of mice, this doesn't work out very well. So spermatozoa were not produced in primate or human tissue pieces. Later on, Yanukainen transplanted Rhesus macaque testicular tissue under the skin or in the scrotum. And they also found that transplanting back under the skin did not result in complete spermatogenesis. There was a meiotic arrest. But if you transplant it in the scrotum, they obtained full spermatogenesis. This was transplantation from between macaques, if I'm not mistaken. And then some years ago, here in Pittsburgh, has been on wonderful experiments. This was autografting of primate testicular tissue. In these experiments, somewhat larger fragments were transplanted under the back skin or in the scrotum. Previous experiments, in general, use tissue pieces of about 6 to 10 cubic millimeters. Here, these tissue fragments were a bit larger and measured about 9 to 20 cubic millimeters. Here, spermatogenesis was produced both in the fragments transplanted under the skin and in the scrotum, and these sperm cells were used for ICSI and resulted in the birth of a healthy female monkey. So this was a very nice proof of concept for testicular tissue grafting. In Brussels, we also developed a technique to transplant testicular tissue inside of the testis. So we call it homotopic grafting. This is also a very easy technique. You just have to open the tunica and put a testicular piece underneath and close it again. This was also found very efficient, as all the tissue pieces that were grafted in this way produce sperm cells. And even if you used cryopreserved tissue, most of them restored spermatogenesis. This technique has also been applied with primate tissue. We transplanted primate testicular tissue to the testes of mice, and also in these experiments we could obtain full spermatogenesis. Then the alternative to testicular tissue grafting is spermatogonial stem cell transplantation. Here as well, first experiments were performed in mice, and the suspension was then transplanted in the efferent duct. The tip of the pipette was put in the efferent duct and moved towards the retitestis, and the cells were released in the retitestis. And in this way, you can fill seminiferous tubules, multiple seminiferous tubules with one injection. This has also been done in primates. Here, the cells were transplanted directly in the retitestis under ultrasound guidance. The cells were transplanted in monkeys that had busulfan. As you can see, after busulfan injection, the monkeys did not produce sperm cells anymore, but about 23 weeks after transplantation, sperm production was established again. These sperm cells were retrieved and used to develop embryos. I know that the group here in Pittsburgh also has done similar experiments to prove this concept, but as far as I know, these results have not yet been published. Maybe, but I think 2 years ago you have presented this in New York. Is that, am I right, Kyle?
I'm sorry, I was multitasking, so what was the question?
Well, you have also done proof of concept experiments in primates by transplanting spermatogonial stem cells in the testes of primates. I think you presented this work 2-3 years ago in New York, but as far as I know, it's not yet published. Am I right?
So this is
not your group, or it is?
Yeah, this is our group.
Also your group.
Yeah, this is our group.
Yeah.
And we have published this, but what remains to be done with this approach is to make a healthy baby.
Yeah.
Yeah. And that turns out to be more complicated than you might think. But I think that's important. So while the tissue transplant in monkeys made a baby already, the stem cell transplant hasn't done it yet. The experiment in monkeys is kind of complicated because sometimes we get endogenous spermatogenesis coming back. So the cells that we transplant then can't compete and produce spermatogenesis. And it's complicated because in order to completely wipe out spermatogenesis, we have to treat monkeys with a very high dose of chemotherapy. That, of course, makes them sick. And so there's a lot of work to do in the medical management of the monkeys. So work still to come. We're funded to continue working on this, and we'll see if we can make a baby soon.
Yeah, thank you. At this point in time, I think we really have a good proof of concept for the testicular tissue grafting. We are still awaiting for proof for the spermatogonial stem cell transplantation. So now the next question is, will we set the step to the clinic? Are we ready there? Are we ready to go to the clinic, or do we still need to perform some preclinical research? That's something I would like to ask to you. How far are you with moving to the clinic? Maybe some of you already have asked for ethical approval or maybe obtained ethical approval. In Brussels, we already have ethical approval to transplant tissue back, but we haven't done any transplantations yet. Maybe some thoughts from the audience. Do you think we are ready yet? We can do it, or we need more research first? Yeah, Rod?
So I would say yes, that we're ready to do this as a clinical trial, and carefully controlled clinical trial with ethical approval, etc., according to local regulations and all that. Really important we do it properly. But I would say we are ready to do it. I think the questions are, who should we be doing this for, and should we be limiting it to those to start with where the risk is low of any particular issue? I'm thinking really about the issue of malignant contamination and reimplanting malignant tissue. So for a patient with a benign condition who's had a bone marrow transplant, etc., that might be a suitable group to potentially try that on first. But I think we've got approval. We haven't got approval. We are applying for approval to do this. Our limiting factor is that we don't have patients that are old enough to even want it yet. So for us, it's going to be limited by waiting for patients to come back, probably.
Yeah, I do agree that, and especially in the first trials, we need to be very careful in selecting the perfect patients. As you said, people who have risk of malignant cells in their testicular tissue, these will not be the patients you will transplant first. Another condition that I think of is they really need to be azoospermic. So you have to perform first a semen analysis. If there is sperm, good news for them. They can go on with IVF or ICSI, but no need to transplant these patients, of course. So yeah, we should really think about who are the first patients we can offer this transplantation to. We in Belgium are very cautious about it. So we have very stringent criteria. That's why we didn't have done the transplantations yet, because some of them had sperm or do not have a child wish yet. They might be 18 years and ask for a semen analysis, but don't want to become a father yet. So in that case too, we will wait until they have a real child wish and then analyze their semen, because it may take many years before spermatogonial stem cells restore spermatogenesis.
I have a comment from the chat as well, real quick. So Scott Gabrielson said, I think we need to verify that sperm produced by transplant in vivo is genetically or epigenetically similar to in vivo sperm. And I think that it would also be important to look at Grady's fertility in offspring for intergenerational issues. Basically just, it's not like transplant produced sperm compared to endogenous sperm is I think the question he's getting at, and that kind of needs to be
So the question is, how sure will we be that the sperm cells will be genetically fine?
Yes.
Yeah, you can never be for sure, of course, but if you transplant, you need to follow up that patients very strictly. And also the children, if they are born, need to be followed up very intensively. And I think we can only know the answer by doing it.
So I'll just add to Rod and Ellen's comments. We are approved now here in Pittsburgh to do both testicular tissue and testicular stem cell transplantation. We haven't done one yet, so we also are carefully screening the patients to identify best candidates, and best candidates for us, at least initially, would not be someone who potentially had leukemia, because I think that's the worst thing we could do for the field, is to have a bad outcome that would set the field backwards. So unfortunately, there's a little bit of selectivism there to identify patients who are the best candidates to give an outcome that would push the field forward, and certainly patients with non-malignant diseases that are getting bone marrow transplant. We also would consider patients with solid tumors like neuroblastomas or sarcomas, which, by the way, those three categories represent 75% of our patients, so it still captures most of them. And then I think one of the questions was, and you raised this, Ellen, is when is the best time then to do a transplant? And for us, we're targeting kind of the late teenage years. So this issue of a family wish may or may not be relevant at that time point. The reason why we're thinking about late teenage years is because in all of the animal studies that have come before, transplant outcome seems to be much more robust in a young recipient than in an older recipient. So for example, if you do a transplant, whether tissue or stem cells, and you're able to produce sperm, those sperm may not be used to make a family at that time, but I think the benefit of doing it at that age is that you can confirm that, yes, now we do have sperm for you, so when you have a family wish, it's here for you, ready to use when you're ready for it.
Yeah, I think that's a good approach, but maybe not for the very first trials to be conducted, because now we don't know when these patients will recover spermatogenesis. Maybe at that time they are isospermic, but 5 years later, they may produce sperm cells from their own. And another thing came to my mind is that you can freeze spermatozoa, but the quality and quantity will always be lower compared to using fresh sperm. So yeah, it's a possibility to do that, but I would not do that for the very first patients.
Ellen, can I ask how much time in between looking to see whether they're isospermic would you put, and then say, yes, that patient's clearly isospermic, and then think about doing a graft?
I'm sorry, can you say that? Can you ask that one more time?
Yeah, so Ellen was talking about that she would assess the patient to see if they were isospermic. How many samples would she take to test that, and the time period between that to really be confident that they were isospermic?
Okay, so if the people come back for a semen analysis, we have the first sample tested. If this is negative, we ask them to come back for a second one. If that is negative as well, we ask them if they would be willing to come back 1 year later, and they can come back every year if they want. If you would be interested to apply for ethical approval, there are a lot of questions that have to be answered. So I have put some of these questions on the next slides.
I actually just had a question for Kyle. So Kyle, if you're thinking about the late teenage years, what would your protocol be? I'm just curious, like how often would you be testing it out with those kids?
Yeah, so first of all,
just thinking about the willingness of like an adolescent.
Well, so first of all, regarding consent, for a patient of that age, there would also have to be an assent too. So regarding willingness, that's something that would be assessed. Completely agree with Ellen that a fertility assessment would be critical, because if they're already making sperm, it indicates that they've recovered spermatogenesis, and there would be no need to do an experimental procedure, and we wouldn't do that. What was the rest of the question?
It's not like once you, I understand that, but once you transplant that tissue,
Yeah.
what would the protocol be?
Yeah, so this is an important, I think about this very deeply, and it's an important and a complicated question. So if you're doing a tissue graft, in this case, you're putting the tissue under the skin. Your objective is not to restore normal spermatogenesis in the testis. That means not to produce sperm in the ejaculate. Rather, the objective is to mature that tissue up to produce sperm, and then retrieve the tissue just like you would a biopsy and tease it apart to release sperm. At least in monkey, that outcome happens within 8 to 12 months period of time. I can't tell you how long it would take in human, but I would guess it would be similar and perhaps a little bit longer than that. So for the tissue transplant, relatively short term. And when you recover the tissue and see sperm, then we will know that the transplant procedure worked in human patients. And unfortunately, in this case, I mean, the human patient is always our last experimental model, or our highest order experimental model. And we may learn things in those patients that we could not have predicted from over 20 years of research. Now, the stem cell transplant, in my mind, is a lot more complicated to interpret. And that's because after we transplant the stem cells, if that patient should start producing sperm in their ejaculate, how will we know whether that was from the transplanted stem cells or whether the patient recovered endogenous spermatogenesis? I propose that there's absolutely no way we could know the answer to that question, or at least it would be very difficult to know. And so if we see sperm in those patients, I'm feared that we will not have answered the question, did the experimental protocol actually result in a positive or beneficial outcome? The only way we could know is to do an epidemiological study where you put 1,000 patients in the non-transplant group, and you know, we'll all be probably retired before we know that question. So I really feel that the tissue transplant has the greatest potential to educate us as early as possible that at least that technique actually produced sperm that could be used for reproduction. The stem cell transplant would be great if we could restore normal fertility. That might be a lofty goal because of the number of stem cells you could get from a small testis. And as I said, we'll never know for sure that the outcome was due to the transplanted cells.
Okay, so the next.
I have a question from the chat. A comment actually, that we should do a testicular biopsy at the time of stem cell transplant to verify there are no stem cells there.
I think that is something that you can add to your protocol, yeah. So for the time being, I have put together 4 more slides about questions you have to ask yourself before submitting an approval, an application for ethical approval. Can you move the slides, because it doesn't do it? Yeah, so the first question is, when should we do the transplantation? Already during puberty, or at the time of a child wish? How long should we wait after finishing the treatment? And would you like to apply an age limit or perform transplantation in all patients who come and ask for it? The next question is, who would you propose a transplantation to? Only in patients who had a non-malignant disease, or also for patients who had a solid tumor, or maybe all patients? Patients who are already in a stable relationship, as we also do for ICSI and IVF. Patients who have proven infertility. And what would you do with patients who are high smokers or have a high BMI? Usually these patients are not included in our ICSI or IVF programs. Would we include them in this program? That is also a question you may ask. And then how would you do the transplantation? By grafting in the testis, in the scrotum, or under the skin? How many pieces would you graft? And what would be the size of the pieces? Would you also consider transplantation of spermatogonial stem cells? And would you do that then in the rete testis? How much cells would need to be transplanted? And would you enrich the cell suspensions for spermatogonial stem cells or not? And these are all, and these are still a lot of questions to be answered. So if you have ideas or comments, please shoot. I think this is the end of my presentation, so I don't know if there is still time for further discussion.
How long is it viable? Like I know in American tissue transplantation, there is a period of time. Do we know with testicular tissue?
Well, as Kyle already said, in monkeys it takes 8 to 12 months before spermatogenesis restores. I think we have to calculate a bit the same time in humans, maybe a little longer. So 1 year.
No, the question is, once you transplant it back, like in puberty, if you transplant it back in puberty, is it still good 10 years later?
I don't think so, because grafts have a limited survival time. So at a certain point, the sperm cells, if there are produced sperm cells, they will, they cannot go away. Right. They will go in apoptosis. So I don't think we can keep the grafts forever.
Right. Okay. So then that would suggest you would transplant the tissue when you're ready to harvest sperm to use, or you're going to have to freeze them or something.
Yeah.
Okay.
Yeah.
Is the goal with these, when you're talking about doing it in late teens, because that's when you get the most robust, is the goal to do the graft and then just freeze the sperm at that point when you can get the most robust? Is that what I'm understanding? Okay. And then are you taking patients outside of your trial to reimplant, like from other centers that have frozen this that aren't approved, or is it primarily for?
So to wrap up sort of answers to both questions, when we did these experiments in monkeys, it was a gamble on when's the right time to take the tissue out, because you want to leave it in long enough that you actually are going to mature the tissue enough to produce sperm. Maybe Ellen's correct that if you leave it in too long, now the tissue begins to deteriorate. I'm not sure we have data to support that point, because nobody looks beyond the point when you get sperm. But at least for me personally, we would monitor the growth of the graft over time. We expect that it would grow, so if it grows, that's a really good sign, because that's the majority of what's in the testis is the germ cells. That means of a fertile individual. So if the tissue is growing, then probably it's producing spermatogenesis. It'll be a little bit of a gamble in the first patients about how long should we let it go and when should we get the tissue out, just for fear that what if we take it out too early and we didn't quite get to sperm yet. So that's one of the issues. The second question was about, I think the question was, well, if you took this out of the testis of a late teenager, then you would freeze. Yes, that's how I would think to do it. And the final thing is, would our protocol accept patients from other centers? And the answer to that is yes, as long as they meet the inclusion criteria. Last call for questions. Anybody else have questions? If not, thank you, Rod and Ellen, for a really tremendous, not only presentations, but also discussion.